talk. Now our second speaker is Professor Afia Zafar, who is consultant microbiologist in the Department of Pathology at Aga Khan University. She will be discussing about mycetoma and diagnostic dilemma.
Assalamu alaikum. First of all, I would like to thank Dr. Iqbal Sumro and his team that they encouraged us to come here and discuss various problems which are very close to your heart as well as हम लोगों के भी अब दिलों में थोड़ा सा आ गया है. Mycetoma and diagnostic dilemma. Mycetoma. If we just concentrate on the top right, you can see that there is a portion which is green. The light green is the belt where mycetoma cases are found in the world and they are reported. You can see that India there are many reports, but unfortunately Pakistan जो कि इस belt के अंदर आ रहा है, खासतौर पे southern part of Pakistan, it's there, but I don't think that any of us has reported any mycetoma case yet. In internet or PubMed, there are 1 or 2 cases. One was from Lahore, and one of my colleagues just said that another colleague, they have published it. But it's most unfortunate कि हम लोगों ने अभी तक mycetoma को नहीं देखा है, though this is a serious issue. And I would like to start my presentation with this case. This is a young man from Sawabi, northern part of Pakistan, and one of our colleagues, he was involved in this case, and we received various samples from him. So this patient, you can see that in Sawabi, in their laboratory, what they could find on microscopic examination, just septate hyphae, and there was no growth. Then they sent a sample. They spoke to one of my colleagues, Javeria, she's here, and they received swab for culture, and they just used few media. I will not go in the detail, but nothing grew, and we just reported gram stain because we received a swab. What is the difference between swab and a tissue? I will discuss it further. And then we received another biopsy material where they smear positive. Culture was done. Patient was very poor, but they and us, we managed it. And what we did, since we have the history, we had the knowledge about the patient. So what we did, we put it for a fungus and different temperature, and after few days, 2 to 3 weeks, usually this organism grow. So then acromonium was found. And this case actually handled by Javeria, so that's why, and Javeria told me this story. So this is the one which we can see on gram stain or microscopy. This is the thing or culture which grow in 2 to 3 weeks time. And this is the patient after the proper diagnosis, concern of a clinician, concern of laboratory, good collaboration, discuss each thing, and then you can see this particular patient. So this is the thing which we are facing in, though it's not very common disease, but it's there, we don't know the endemicity. So what I will do, I will just go through the laboratory modalities and what you should send to us for a good diagnosis of mycetoma, because believe me, we do have mycetoma in Pakistan, not only in southern part, even in northern part, but there are some problem with the diagnosis. We all know, for my junior colleagues, we all know that it is a disease where there are subcutaneous painless swelling, there are multiple discharges and grain, and this is caused by fungus as well as bacteria. This is the problem. What to treat, what antibiotic or antifungal we should give. So this is the problem. That's why we should know the genus, and sometimes species level, it help us. Deformity is common, and we have already discussed this mycetoma belt in the world. So what are the problems? The problem is that you can see that the first 3 photographs over there, this is just a small painless lesion. You know better that what is the differential diagnosis, but from my perspective, from laboratory, maybe it's mycetoma, maybe it's TB, maybe it's leprosy, or something like that. So there are many things which are painful, but this is the reason why patients, they don't come to us, and many a times we clinician, we don't go up to the extent we should go for. They are poor, they can't afford it, they can't afford health, they can't afford a hospital. सिंध से लोग आते हैं, किस मुश्किलात से आते हैं, किस तरह आते हैं, बेचारे चले जाते हैं. एंड ऑफ द डे ये जो लास्ट वाला ये हमारी लोकल पिक्चर है सिंध की जो मैंने इनके पेशेंट की ली थी. सो दीज आर द प्रॉब्लम, दे कैन नॉट ट्रेवल. इसी वजह से सूडान है तो इजिप्ट है तो अफ्रीका है, sorry, South America hai, India hai, and us we do have these diseases, but unfortunately we don't know the burden. So कहते ये हैं कि in endemic region mycetoma must be considered in the differential diagnosis of subcutaneous swelling, which is painful and which you think that it can be something like that. ये just to show you that there are two big groups. One is eocytoma group, which is fungus, and actinomycetoma group, which is bacteria. They are fastidious organisms, they are difficult to grow, and they are not on the surface, and is a big group of organisms, and sometimes laboratory find difficulty in growth of them. We don't discuss the sensitivity. Challenges in the mycetoma, as I already discussed, that it is the diagnostic challenges. Invasive procedure has to be there, it's time consuming, it requires experienced personnel, आंखें ट्रेंड हुई हुई, और उसके बाद माइकोलॉजी लैब विच इज़ अ डिफिकल्ट थिंग, और बड़ी अभी तो लग्जरी नज़र आती है, बट वी शुड हैव इट, स्पेशली इन स्किन सेंटर्स. दे शुड हैव सम लेबोरेटरी विथ एक्सपर्ट to diagnose these cases. Cost is another problem. So what I will do in next few slides, I will very briefly try to tell you or discuss you or let you know that what are the different modalities available in laboratory. So the best thing or the nucleus of the diagnosis is mycetoma grain. Mycetoma grain, we all know that this is the grain, it is a micro colony which is over there, and we need it for the final diagnosis. And we differentiate them with the help of size, color, consistency, what they are. किसी में काला होगा, किसी में पीला होगा, किसी में पिंक होगा, किसी में white होगा, किसी में pale होगा. So these are the training of a good dermatologist as well as a mycologist, microbiologist, that they can see that what it is, so they can guess what type of fungus or bacteria is going to be. So इस detail में यहाँ नहीं जाएंगे, but then how to get a good sample. Deep surgical biopsies are required to get some these grains. Grain present on the surface of open sinuses are commonly not viable and often contaminated. This is the problem. Contamination grow हो जाती है, ये नहीं grow होते हैं. Number 2, ये open sinuses में होते हैं because of the exposure in the environment. They are not viable. They are dead. हमें swab आप भेजते हो, हम swab में से कुछ नहीं कर पाते हैं सिवाय gram stain या wet prep पे कुछ दिखा दें. Therefore, biopsies must be immediately transferred to laboratory because they are fastidious organisms. They are difficult to grow. They don't grow that easily. Number 2, histopathology section, they have their own importance, so try to divide your usually cancer वाले कहते हैं कि sample को 2 में नहीं divide करो, but for the microbiology lab and histopathology lab, the transport medium is totally different. Micro वालों को saline में चाहिए होता है, उनको formalin में चाहिए होता है. So try to send some sample in formalin to microbiology and some to histopathology. What we do, we take the sample, we take the grain, or we wash it with saline, and वो जो ऊपर top पे तस्वीर है, we crush it, we make a wet prep. Wet preps कुछ नहीं, simple microscope में डालकर देखते हैं, and we can see that hyphae. ये hyphae बहुत suggest कर देता है कि ये कोई mycetoma का fungal element है. Under the microscope, good trained eye जो वो बता देगी कि ये fungus की तरफ जा रहा है या bacteria की तरफ जा रहा है. It's quite simple for us. Sometimes we do just KOH and then we do gram stain, and अगर उसको eumycetoma and actinomycetoma को different करना है तो फिर हम तो gram stain में भी size, shape से पता लगता है, and then Zeal cell stain to differentiate between nocardia and actino, क्योंकि एक positive होता है एक negative. So these are very fast tests. They are of low sensitivity क्योंकि इसमें बहुत कम material हमें नजर आ सकता है microscope में, but they are cost effective and they need trained personnel in the lab. फिर हम इसको culture करते हैं, and as you know that the culture is a difficult task. They may not be alive. मुख्तलिफ मीडिया में डालते हैं, फिर इनको देखते हैं तो दे ग्रो डिफरेंट टेम्परेचर पे इंक्यूबेट करते हैं. दे मे ग्रो फ्रॉम फ्यू डेज टू 3 weeks और समटाइम 4 weeks. लिमिटेशन क्या है कि कुछ को हम नहीं ग्रो कर पाते हैं, टाइम बहुत लेता है, एक्सीडेंटल कंटेमिनेशन हो जाए तो ऑर्गेनिज्म नहीं समझ में आती है. सो दीज आर दी प्रॉब्लम, एंड उसके लिए एक बड़ा अच्छी पर्पस बिल्ट लेबोरेटरी चाहिए होती है, जो कि मेरा ख्याल है हर जगह पर होनी चाहिए. देन साइटोलॉजी एंड हिस्टोपैथोलॉजी. साइटोलॉजी For cytology, try to send a fine needle aspirate, अगर आप कर सकते हैं, एक जगह से ज़रा सा नहीं लें, रिकमेंडेशन है कि उसको डिफरेंट डायरेक्शन से लें, और उसकी स्लाइड भी बनती है, उसके ब्लॉक भी बनते हैं, उनको फिक्स किया जाता है, then they do it under the microscope in the laboratory. So presence of grain is again mandatory for the diagnosis, because वो होगा तो कुछ नज़र आएगा और उसकी कुछ provisional diagnosis दी जा सकती है. Results cytology के usually comparable to histopathology हैं, लेकिन इसमें causative agent का नाम देना ज़रा सा मुश्किल होता है. Technique is simple for you and for us as well, because it's just the secretion, we fix it on the slide and we see under the microscope. और अच्छा histopathologist या trained cytologist, they pick it. May be painful और हो सकता है हम infection introduce कर दें. ये एक ग्रेन्युलोमा है जो माइक्रोस्कोप में उनको नजर आ रहा है, एंड इट्स वेरी सिंपल, जस्ट इन द सेंटर देयर इज माइक्रो कॉलोनी और पूरा एक्यूट इन्फ्लेमेटरी रिस्पॉन्स है. हिस्टोपैथोलॉजी, deep biopsy that contain grain is always needed to establish the diagnosis. कहते हैं कि सिर्फ एक सिंपल सर्जिकल बायोप्सी लोकल एनेस्थीसिया में करने का बहुत फायदा नहीं होता है. इट शुड बी ए सर्जिकल वाइड लोकल एक्सिशन, डीप इंसिशन या ट्रू कट बायोप्सी. स्टेनिंग वही है जो हम लोग माइक्रो में करते हैं, एंड देन हिस्टोपैथोलॉजी में ये अपना वेरियस स्टेन करते हैं, एंड देन दे सी इट अंडर द माइक्रोस्कोप. सीरो डायग्नोसिस, दो इट हैज बीन डेवलप्ड फॉर फ्यू फंगल इन्फेक्शन, यूज माइसिटोमा एंड एक्टाइनो, बट दे आर नॉट इन प्रैक्टिस एट द मोमेंट बिकॉज दे हैव वेरी पुअर सेंसिटिविटी एंड बहुत ही cumbersome तरीका है एंटीजन या एंटीबॉडी डिटेक्ट करने का. सो दे आर नॉट वेरी पॉपुलर एट द मोमेंट, सो दे आर नॉट इन प्रैक्टिस एक्सेप्ट वन विच वॉज अप्रूव्ड लास्ट ईयर, जो मेड्यूरेला के लिए है, जो अभी कहीं कहीं पे किट मिल रही है. Molecular, as Dr. Kossar said, molecular is the future. Currently they are very expensive, but they are sensitive, and they are the one they give us ID. What is this organism? How to treat? इसमें वोरी यूज करना है कि इसमें ट्रा से काम चल जाएगा, कि इसको कीटोकेनोजोल से काम चल जाएगा. So this is the thing which should be the future, and I am very optimistic that it will be with us. Currently is not, we cannot use it in the field or in very small remote area, which is the problem. Just to tell you कि इसमें ये इस तरह से आ जाती हैं, जैसे बैंड नंबर 5, 6, 7, 8 को आप देखें, थिक बैंड है, विच इज जस्ट टेलिंग एज पर 10 नंबर कि ये पॉजिटिव कंट्रोल है. सो ये दिस गिव्स द जस्ट द नेम अप टू स्पीशीज लेवल ऑफ द ऑर्गेनिज्म. सो जस्ट टू समराइज इन द हियर फ्लो चार्ट, डायग्नोसिस का क्या है, FNAC किया, FNAC फाइन नीडल एस्पिरेशन, माइक्रोस्कोपी पॉजिटिव, कल्चर कर लें, हिस्टोपैथोलॉजी कर लें. FNAC अगर नेगेटिव है, then one should go for biopsy, go for the exact name of the organism, by histopathology, by culture, molecular भी